So I think at our session, there was a lot of really great discussion and good ideas about what we're really doing in order to improve patient outcomes. Combination therapies, in particular ones that have a venetoclax-based backbones, are definitely demonstrating improvements in progression-free and overall survival for patients, particularly in comparison to chemoimmunotherapy with FCR and BR. We see that in CLL13, we've seen that in the UK FLAIR trial, and again, we've seen it in the past, for example, with E1912 in the Alliance study for patients with frontline treatment with CLL. What I don't think that we really know yet is whether and what the correct treatment strategy should be for upfront treatment. We'll get data over time from CLL17 and as the data from CLL13, which compared chemoimmunotherapy to venetoclax rituximab, to venetoclax obinutuzumab, and to venetoclax obinutuzumab and ibrutinib. I think we'll start to see a little bit of a difference in trying to understand how we maximize the duration of maximize responses in the frontline setting, so that way we're able to maximize time off treatment and progression-free and overall survival for our patients. And I think MRD directed strategies will be really important for us to do these things, as we're sort of seeing with data from the FLAIR trial and from Captivate, that really these patients who do get to an undetectable MRD response at the end of a fixed duration treatment have the most time off of treatment and really do have the most benefit. Dr. Iyer presented data looking at Richter's transformation, which remains one of the areas of unmet need for our CLL patients. There's some data about PD-1 inhibition in combination with zanubrutinib that was published recently, and I'm really excited to see how we can improve our therapies there to maximize survival. Finally, I think the approval of Pirtobrutinib on December 1st is definitely a step forward for our patients as well. So the approval for Pirtobrutinib was in patients that have seen a prior covalent BTK inhibitor and have also received a prior BCL2 inhibitor, which for most patients is venetoclax. That patients that had progressed on both of these therapies really were an area of unmet need. When I think about third-line treatment for CLL, pre-Pirtobrutinib, the options weren't very good. But now with Pirtobrutinib, we've really got a great third-line treatment option that's commercially available for patients.